Dr. Lisa Horowitz is a pediatric psychologist and senior associate scientist at the National Institute of Mental Health at NIH. She's a pediatric psychologist and senior associate. I just read that. She did receive her doctorate in clinical psychology from George Washington University and completed a pediatric health service research fellowship at Harvard Medical School and obtained a master's in public health at the Harvard School of Public Health. The major focus of Dr. Horowitz's research has been in the area of suicide prevention in the medical system that involves validating and implementing tools for clinicians such as the Ask Suicide Screening Questionnaire, ASQ. She's also one of the co-authors of the Blueprint for Youth Suicide Prevention released by the American Academy of Pediatrics in the past March. Dr. Horowitz is collaborating with hospitals and outpatient clinics both nationally and globally, assisting in the implementation of suicide risk screening and management of patients who screen positive using the ASQ online toolkit, and youth suicide risk clinical pathways. So it's been a joy to get to spend time with you, but also she's got some really practical, like how do we do this suicide screen thing fast, easily, with a plan, and this is practical. So I'm really glad that you're here, and I look forward to hearing.
Thank you. Can you hear me? Okay. So thank you, Dr. Gibson, Kim Schuler, for inviting me. I have to give a special thank you to Jenny because I did what Dr. Gibson said you're not supposed to do. I did bring my PowerPoint on a flash drive this morning and sort of made her nervous, but she made it happen, so thank you. It is such a privilege to be here today speaking to you about this really critical public health problem that I feel so passionately about, because you all are on the front lines of this public health problem of suicide. So every single one of you can make a difference. And so that's why it's just such an honor to be here talking to you about this. And I'm really looking forward to making it a discussion. I'm up here for a long time, but I really am looking forward to your questions. So that is the NIH, the National Institutes of Health in Bethesda, Maryland, where I work. And I have to put this slide up because I do work for the federal government, so I have to disclaim everything I say. But actually, the National Institute of Mental Health, where I come from, one of our top 3 missions is to reduce suicide. So I also have no conflicts to disclose. I will disclose that I am originally from New Jersey, so I tend to talk really fast and have a weird accent, so hopefully you'll understand me. Okay, so I always like to start my talk with my take-home message, my last slide. And actually, before I even start that, can I just want to see who you all are. So can you raise your hand if you work in a hospital? I just want to see. Okay. And how about an outpatient primary care setting? Okay. Anybody from school systems? Emergency departments? Okay, community health centers. Okay, great. And did I miss anybody? All right, great. And can I see a show of hands for people that have been touched by suicide in some way, either professionally or personally? Yeah. Okay, so suicide is a relatively rare event, but that happens every time I give a talk. Almost every hand goes up, and that's because even though it's a relatively rare event, the ripple effect of suicide are endless, and they affect us all. So what I'm going to talk about today is, my take-home message is, suicide is a major public health crisis at this point. But we have tools, and there's so much we can do. And we can turn research into practice. And so I'm not going to go too deep into the research, but I'm going to show you some evidence-based ways that I think we can reduce suicide. I'm going to talk about screening, right? And screening is a very structured way to start a very awkward conversation with a patient or a client, right? And I'm gonna talk about how it becomes manageable. And the way it becomes feasible and manageable is this 3-tiered pathway. You're gonna hear me say this a lot. It starts with a brief screen, and then the second step of the pathway, the most important part, is a brief suicide safety assessment, because that determines what happens next with the patient. And then lastly, all patients, no matter what interventions you can provide, need to be discharged with a safety plan, lethal means safety counseling, and 988, which is our National Suicide Lifeline and crisis text line. Okay, so let me put suicide into a public health problem perspective. I'm going to go back to 2020. And so this is no surprise. You know, the big public health problem in 2020 was COVID-19. And so 350,000 people died, and that was 960 people per day. And for young people, it was about 10 per week. And then motor vehicle accidents. That kills over 43,000 people in 2020, about 118 deaths a day, about 20 deaths a day for young people. And you might be surprised to see that suicide is between those two public health problems. 46,000 people died in 2020 from suicide, 126 people every day, and 18 deaths a day for young people. So what did we do from a public health approach to this problem? Well, for COVID-19, you know, you couldn't go anywhere without seeing signs for wear your mask, social distance, get your vaccine. And this reduced deaths and illness from COVID. And then for motor vehicle accidents, well, wearing your seatbelt used to be a public service announcement, right? But now it's a law, and there's drinking and driving laws, and kids have to take driver's education before they get their license. So we did a lot from a public health problem approach, and we reduced morbidity and mortality for motor vehicles. If I put this on, this is the old suicide lifeline, like how many people are familiar with this? And that's because mental health as a public health problem is still so stigmatized, and especially when it comes to suicide. So there's so much more we can do about this. And I just wanted to show you for young people that death from motor vehicle accidents and suicide are almost equivalent. All right, so I'm going to do some numbers first, right? So this is suicide, death by suicide in this country. It's now the 9th leading cause of death, and this is the suicide rate over time, and you can see it creeps up. And in 2021, it killed over 48,000 Americans. And then I wanted to show you the timeline for the youth. Looks very similar, keeps creeping up. And so if we look at youth deaths in this country, right? Kids aren't supposed to die. They're supposed to grow up and live long, healthy lives. But if we look at the number of youth deaths, almost 20% were from something that is potentially preventable, suicide. Like, so can you imagine if I told you that 20% of youth deaths was from an infectious disease? You can imagine the public health outreach that would occur, right? But this is staggering. These are staggering numbers to me. And again, COVID-19 didn't do us any favors. It exacerbated an already really bad public health problem. So suicide rates by state are not equal. As you can see, the highest rates are in Wyoming and Montana, lowest rates in New Jersey and Washington, D.C. And I looked into Arkansas, and Arkansas has the 12th highest rate of suicide for all ages. Now, if we look, I wanted to show you what's happening over time. So the gray bar is suicide rates in 2001, and the red is 2021. And these are females. Now, if you can see that this is on the bottom, you can see, oops. Sorry, Jenny. On the bottom is across the lifespan. And then you can see that young people have fewer suicide deaths than older people. But I want you to look at the rates, and the rate changes over time, and look at that 10 to 14 rate, right? Those increased 283% So the rates are increasing. It's at staggering numbers. Now there's disparities in death by suicide, and there's significant differences in the rates by race, ethnicity, sexual orientation, gender identity. And what we find is that these disparities don't stem from the identities themselves. They reflect more systematic inequities and barriers to healthcare. So I just want to show you, this is suicide rates over time, across the lifespan by race. And you don't have to read every bit of it, but the black outlier line is American Indians, Alaska Natives. So American Indians have the highest rates of suicide than any other race or ethnicity. And you can see it disproportionately affects young people. And then this is suicide behavior, and the blue dotted line are Black youth. Black youth now have the steepest increase in suicidal behavior. So much so that the Congressional Black Caucus convened an emergency panel, and they put out something called the Ring the Alarm report. And I encourage you all to look at it. It called for more suicide intervention and research on Black youth. So again, I told you over the pandemic, people say, well, what happened to the suicide rate? Well, it increased, right? So we had 212 excess, this is for young people, deaths. And again, it varied. It wasn't equal. It varied it was worse for males, worse for those age groups, the 5 to 12-year-olds, the 18 to 24-year-olds, for American Indians and Black youth, and method increased for people using firearms. So there's many underserved, understudied populations, and it's not just by race, but also people who, LGBTQ+ individuals, people with neurodevelopmental disorders like autism. Kids in the child welfare system have 6 times the rate of suicide. Anybody in a detention center, and then in rural areas. All these people are at a higher risk for suicide. And so I'm talking today about screening, starting that awkward conversation in a professional way. And we believe that screening brings health equity, right? Universal screening. If you're screening everybody, then you're not picking out, I'm gonna screen you, you don't look suicidal, I'm not gonna screen you, right? So we think screening brings health equity, and I'm hoping to convince you of that. So suicide's still a relatively rare event. What's more common than suicide is suicidal ideation and suicidal behavior. So you can just see these numbers. Millions of Americans are attempting suicide, are thinking, 12 million reported thinking about suicide, right? And then when we look at the Youth Risk Behavior Survey, that's when the CDC goes into your average high school student across the country, tens of thousands. They ask about smoking, drinking, safe sex, and they ask about suicide risk. And 10% of your average high school student self-reported that they attempted suicide in the previous year. And 22%, that's almost a quarter of our young people, self-reported that they seriously considered killing themselves. So these are the high risk factors for suicide. I'm not going to go through all of them, but I highlighted the most potent ones. And so previous attempt. So we have a saying in psychology, past behavior is best predictor of future behavior. This is very true for suicide risk. Anyone who's tried it in the past is more likely to try it again in the future. And then we have mental illness. So people with a diagnosable mental illness are more at risk for suicide. And then I have one at the bottom that's often overlooked, medical illness, right? People often don't think about this, but people who have medical illness are at higher risk. So if you look at these risk factors, you probably know and recognize a lot of people, and maybe yourself, that has these risk factors. Most people who have these risk factors are not going to die by suicide because they're risk factors, right? What's more important than risk factors are warning signs, right? So if you were a triage nurse in an emergency department and someone came up to you with risk factors for a heart attack, let's say they were, had a heart attack in the family, had high blood pressure, high cholesterol, smoker, obese, and they walked up to your triage desk, you're not going to think they're having a heart attack, right? But if they come in clutching their chest in pain and sweating profusely, which are the warning signs of a heart attack, you're going to think heart attack. So the same thing goes for suicide. So these are the warning signs for suicide. The first one seems so obvious, right? Somebody talking about wanting to die or kill themselves. But surprisingly, this one is often overlooked as a warning sign because people don't always take it seriously, right? I was part of a study that looked at 5 to 11-year-olds who died by suicide, who died. And a third of them had reported, thinking about killing themselves to an adult. But we often don't take this seriously. So it's important to take all talk of suicide seriously. And then feeling hopeless, trapped, or like you're a burden, or people who start acting reckless, or drinking too much. And then the signs of depression, right? Sleeping too little or too much, withdrawing, being isolated. These are all warning signs that someone might be at imminent risk for suicide and they need help at this point. Okay, so I just laid some very sobering statistics on you, but I'm promising you this is not a downer talk, okay? Because these statistics are a call to action. And like I said in the beginning, every single one of us can make a difference. And so this is a talk of hope and action because there's so much we can do. So I couldn't resist, I had to put this slide up next, right? Hope and action. And I know you guys have some a new coach coming, so I thought I would use that. All right, so it's not easy to make people laugh during a suicide prevention talk, so thank you. All right, so it is a good time. I talked about stigma, but it is a good time for mental health, actually, because all these celebrities are talking about not only mental health, not only depression, but suicide. Right? So this is actually a good time for some hope and action. So I'm fortunate enough to be part of a research team at NIMH that asks, can we save lives by screening for suicide risk in the medical setting? And when I say medical setting, I'm going to broaden it to reach all of you because it's really any setting where we come into contact with people and maybe even in your own lives, right? In your own families. So why did we pick the medical setting? Well, if you look at death registry studies, so people who died by suicide, the majority of people, and this not only goes for adults but for kids who die by suicide, have visited a healthcare provider months, sometimes weeks, sometimes 1 week before they die, right? But the problem is they don't walk into the doctor's office and say, I'm thinking of killing myself, right? So if someone doesn't ask them directly, are you thinking of killing yourself? They most likely won't talk about it. So the majority of suicide attempters go unrecognized because the majority of settings don't screen for suicide risk, right? The provider isn't starting that awkward conversation, which is hard, and also the provider has so much to do. So we're going to talk a lot about that. Okay. What do you think is the number one myth, I'll call it, of suicide? What's the number one most common concern? Why don't people talk about suicide? Exactly. So people worry that if you ask questions to people about suicide, you're going to put the idea in their head. You're going to make them think about it. Well, I promise you that it doesn't work that way. And in fact, you don't have to take my word for it because there's at least 4 research studies that refute this myth that say not only is it not harmful to ask people about suicide, it's the opposite. It's helpful. The best way to save someone's life is to ask them directly, are you thinking of killing yourself? And then you have to brace for that no answer, right? And so that's what we're going to talk about today. How do we brace for anything other than no? And how do you then be the bridge to getting them help? Okay, so I'm going to because some of you work in a hospital, I'm going to show you that, suicide in hospital is actually one of Joint Commission's top sentinel events. And it's a devastating event. It's a sentinel event is when a patient dies unexpectedly. And so the Joint Commission was looking at their data, and in the top 5 for years, suicide is a top event. And people think, well, this is occurring on all the behavioral health units, right? But that's not true. Almost a quarter of the suicides occur in non-behavioral health units. Places like the ICU, the emergency department, the cancer units, the med-surg units, right? So in 2016, you don't have to read that, the Joint Commission issued a sentinel event alert, and they recommended that hospitals screen not only behavioral health patients, but all patients for suicide risk. This is not a mandate, but it was a recommendation. So I'm going to show you, just because some of you work in a hospital, what do you think the #1 most frequently reported sentinel event is in a hospital? Right? Think, why do people die unexpectedly? You're going to be surprised to see. Anybody want to take a guess? What is it? Sadness, did you say? Sadness. Well, I'm saying any event in a hospital, in a medical setting. So what you'll see is the #1 in 2022 was fatal falls, right? And I highlight this because, suicide used to vie with wrong site surgery. That used to be the number. Suicide and wrong site surgery used to go 1 and 2. But now suicide is in the top 5. But I put falls up because everybody knows you can't go to a hospital without being assessed for fall risk, right? Hospitals have routinized way of screening for fall risk. They do not have routinized way of screening for suicide, and it's right up there with falls. Okay, so let's talk about screening. These are some pictures. We do screening all the time. Everybody gets their blood pressure taken. That's a screening. That top right is the NIH where we screened for COVID, in 2020. People get screened in an airport, and some kids even get screened before they go on a roller coaster, right? So screening is popular. So now, and Dr. Rogers, you'll appreciate this, I'm going to put up I'm not expecting you to read that, but that is what pediatricians are asked to screen for. That is at every age, all the conditions. So they're asked to do a lot, and people often say, oh, I have to screen for so much. Why should I screen for suicide risk, right? Well, because 20% of our youth deaths are this is what kids are dying from. Because suicide is the second reason why kids die, okay? So this is what the American Academy of Pediatrics, the AAP Bright Futures, puts out for pediatricians. You got to screen for this. And in March of 2022, the best thing to happen to suicide prevention ever in a medical setting happened. The AAP said that pediatricians should screen for suicide risk alongside depression. And they said for 12 years and above. So now more providers are really starting to think about screening for suicide risk. Okay, we'll talk more about that, but I want to really point out, and this is such an important point, so I'm going to underscore it, that there's a difference between screening and assessment, and people often confuse these two things. Screening is a very rapid way to identify someone that needs further assessment, further evaluation, right? Assessment is a much more comprehensive evaluation. It confirms the risk. It guides next steps. But they are not the same thing, and you'll hear people use this interchangeably. The ASK, or the ASQ, what I'm going to talk about today, is a screening tool. It's identifying someone that needs further evaluation. It's not meant to diagnose. It's not even meant to predict. It's meant to tell you, oh, this person needs further evaluation. So what are the valid questions? This was our research question. What are the valid questions that providers, healthcare providers, can use to screen people for suicide risk in the medical setting? So without too much detail, we launched this study called the ASK study. And most tools go from the adult world to the pediatric world. And in pediatrics, we use a lot of adult tools. But I'm very proud to say the ASK went from the pediatric world to the adult world. So it started out in 3 pediatric emergency departments at Boston Children's, Children's National in DC, and Nationwide Children's in Columbus, Ohio. In this study, we had pediatric patients and emergency department patients, And without going into too many details, we developed a tool called the ASK or the ASQ. It had really good true positive rate, which is sensitivity, really good true negative rate, which is specificity, it limits false positives. And so I'm going to show you the ASK. And it's meant to be very blunt and very direct. So you might be surprised at how blunt and direct it is, right? It's 4 questions, it takes 20 seconds. In the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? In the past week, have you been having thoughts about killing yourself, and have you ever tried to kill yourself? If the patient answers yes to any one of those 4 questions, you ask a 5th question, which is the acuity question. Are you having thoughts of killing yourself right now? So what we know from big data sets, like there's a Parkland Hospital in Dallas, Texas, that showed us data on 90,000 asks. So I have some pretty big data sets. The majority of people that you give this screen to are going to look like this. They're going to say no, right? And it's going to be a negative screen. And that's because most people are not at risk for suicide. There are some people at risk, and that's the important ones we want to identify. But the reason why it's universal screening is feasible is because 97% of your patients are going to look like this. So it's a 20-second, you just destigmatize suicide by asking about it, and you move on with whatever else you're doing. But there's 2 ways to screen positive on the ask. So if someone says yes to any one of those or multiple, then you ask that 5th question, are you having thoughts of killing yourself right now? And there's 2 ways to screen positive. There's the non-acute positive, the person that says no to question 5. Now, out of all the positive screens, the majority of positive screens are not an emergency. They're the non-acute positives. And this is a really important point that I'm going to keep talking about. Not everybody who has a thought about suicide is in an emergency situation, right? And we want people to talk about it. And I know from not only this data set, but data all over the country, that the majority of your screens and the majority of the positives are going to look like this. However, we do have to be prepared for when someone says yes to that 5th question, because that's the acute positive screen. That is the emergency. That is the don't leave the person alone, full-on safety precautions, maybe a 1-to-1 observer. That's the emergency. And you know, so in an outpatient setting, behavioral health patients screen acute positive more often than non-behavioral health patients in the setting. But it's still the rarer occurrence. Okay, so the ASK has been validated in the inpatient through research in the inpatient medical surgical unit, the outpatient primary care and specialty clinics, and with adult medical patients. We're looking at it now. There's trials going on in schools, child abuse clinics, detention facilities. We're so excited that we now have a partnership with the Indian Health Service. They are going to roll out the ASK to all 130 medical facilities across the country, and we're partnering with them on that. And we are testing it in a neurodevelopmental disordered population at 2 hospitals. The ASK has also been translated into over 23 languages, and it's being validated in some of the countries that speak those languages. We also, because we were worried about the disparities in the suicide rates, we also looked into if the ASK performed the same in white youth as black youth, and we actually found very strong psychometric properties and evidence that the ASK worked well in black youth as well. So in some of our studies, we asked kids, you know, should nurses screen kids for suicide risk in a medical setting? And I just want to show you some of the answers. 95% of the kids thought we should be screening, because a lot of kids, especially teenagers, get sad and don't have anyone to talk about it with. So if a kid is already in the ER with people who are trained, it's a good time to talk. Or because sometimes when no one asks them, they feel no one cares. When someone asks, they know someone cares about them. Now, we also looked at the kids that responded, I don't think you should screen. So what did they say? Well, you should only screen kids that have mental health problems, some of them thought, which, does anyone know any of those kids? No. Not everyone feels comfortable telling people about their problems, and sometimes they can lie. So I think that's true. We asked parents, what do you think? And about 71% of the parents were in favor of screening in an outpatient setting. 8% were not. And a good portion, 16%, didn't know how they felt about it. And when we said, well, why do you think we should screen? They said, well, kids feel comfortable at a doctor's office, or teens might not be comfortable telling their parents about it. And why not? Well, this is going to make my child think about suicide, so there's that myth right there. And the child's at the doctor's office to fix a physical ailment, right? So that's a separation of the mind and body, which we know you can't separate. Okay, so we're going to talk now about screening for suicide risk specifically. So before that, how many people know how many people screen for depression here? Okay, so when the Joint Commission came out and when the AAP came out and said, okay, now it's time to screen all patients for suicide risk, people thought, oh, well, we're screening for depression. Many people using the PHQ-9, which is a very popular depression screen. That's the same thing, right? If you're screening for depression, it's just like screening for suicide risk. So we don't have to do anything more because we're screening for depression. And it just didn't sound right to us. So we looked into it in the PHQ-9, and I'm not in any way slamming the PHQ-9 here. It's a really good depression screen, right? It's 9 items that kind of go through the symptoms of depression, and that 9th item is called the suicide risk screen, right? So that item is, how often have you been bothered by the following symptoms during the past 2 weeks? Thoughts that you would be better off dead or of hurting yourself in some way. There's 2 problems with this question. I gave you a hint, right? What are the problems? So first, it has an or in it. So if you ask someone a question with an or in it, you don't know what side of the question they're responding to, right? It might be the first side, it might be a second side. So that or makes, and you know, the first part is, have you ever thought you would be better off dead? So if you're a chronically ill 70-year-old person, maybe you thought that you'd be better off dead, and it might not have been in a suicidal way, right? Or if you know, that could be a thought that many people have that's not suicidal. So the PHQ-9 over-detects and sometimes under-detects, because the other thing it does is it says hurting. It doesn't say killing yourself, it says hurting yourself. And we know that both adults and especially kids, they think of hurting and killing as 2 different things, right? So it's not direct. And so there's at least 13 studies now showing that while the PHQ-9 is better than nothing for suicide risk screening, it's not sufficient, it's not adequate. But we wanted to look ourselves. So I'm showing you data now from over 700 adults in our Ask Adult Medical. This was a inpatient med-surg unit. 116 of them screened positive for suicide risk. 175 screened positive on the PHQ-9. And 49 of them endorsed that 9th item on the PHQ. And if you put this together, what you see is had you only screened with the PHQ, you would have missed 1/3 of the kids at risk for suicide, adults at risk for suicide. And had you used that 9th item only, which a lot of places only screen with that 9th item, you would have missed 63% of the adults at risk for suicide. So the bottom line of this is, by all means, screen for depression, because that's even more prevalent than suicide risk. But if you're going to screen for suicide risk, then use a suicide risk specific screening tool. Now, there's also places that screen like this. They do this sequential screen. They start with a PHQ-2, and if that's positive, they give the PHQ-9, which is a valid way to screen for depression, right? And if that's positive, then they give the suicide risk screen. Now, there's no research showing that this is a valid way to screen for suicide risk. You're going to miss a lot of people, and why do you have to make a patient jump through all those hoops, right? So what we did is we stuck the ask on the bottom of the PHQ so that people could have one tool, and it just adds 20 extra seconds. All right, so 20 extra seconds sometimes is a lot of time too, right? And so universal screening has to be feasible. It has to be practical. It has to be something that everybody can do without, making their waiting room stack up. So there's this evidence-based 3-tiered pathway now that I believe in, and it starts with the brief screen, and then it's followed by the most important part, the brief suicide safety assessment, which takes about 10 or 15 minutes, and maybe many of you in this room would be doing a brief suicide safety assessment. It is not a full mental health evaluation. It's not a full psychiatric evaluation. It's meant to further triage that screen. It's meant to say, this patient screened positive, and you know what, now, what do they need? Well, if they're in the emergency room, maybe they need a psychiatric evaluation. If they're in an outpatient setting, maybe they can come back for another mental health evaluation. Maybe they have integrated behavioral health and it's happening all at once. Or no further action is necessary at this time. What I've learned from consulting on implementations across the country is that there's 100 different ways to do this pathway. It is not rigid. It is meant to be flexible, and every single setting needs to do it in a way that meets their needs, that makes it workable. It doesn't have to be perfect, it just has to be good enough. So let's talk, the first tier is the brief screen, right? So we are recommending that you screen all people ages 10 and above. The AP says 12 and above, and that's okay to start at 12 too. But because I showed you those data on 10 to 14-year-olds, we like to start at 10. And then patients who present with behavioral health chief complaints, it's good to go down to age 8. And then sometimes people say, well, what screening tools should we use for kids under 8? So there are kids under 8 years old who have symptoms of suicide risk. But there's no screening tools that we have for those little kids. So what's more important is to recognize the warning signs and then do the assessment. If a parent tells you every time I discipline my child, they put their hands around their throat, or they try to run in front of traffic, then you do an assessment. You don't have to detect it, right? Screening's meant to identify it. If you already know it's on board, you don't have to screen. You do the assessment. So the screener, anyone who's trained can screen, and training takes about 15 minutes. We have some available in our toolkit online. It's important to administer the ask exactly as it is, because every single one of those questions was tested through research. So sometimes I'll do a training and then I'll come back 4 months later, and we train nurses sometimes, and the nurses will say to me, well, I changed the questions because we didn't really like them. So, and I'm always like, no, don't change the questions. Like, so the questions aren't supposed to be changed, because then you don't know what you're measuring, right? So it's really important that the questions are awkward at first, but then after you do a few, it gets more comfortable. Anyone who's cognitively able to answer questions, all the other questions you're asking them, can answer a screening tool. And then it's important to look at the ask in real time so that nobody leaves a waiting room and sometimes people give the ask verbally, and sometimes they have them fill it out on a tablet or a piece of paper. And you don't want the patient to leave and then you see that they screen positive. So if you're going to give it out without asking, then you have to look at it in real time. And then you report the findings to the responsible person who's going to do the brief suicide safety assessment. Okay, so that's screening. What happens when a patient screens positive, right? This is even more important. So here's what should not happen. And again, this is, if you get just 1 point of my whole talk, this would be it. We cannot treat every person who has a thought about suicide like they're an emergency, because otherwise they end up in an emergency room in a paper gown, their belongings are taken away, they're given a very costly one-to-one sitter, and they feel like they're being punished. Like, you might be the first person that's asked them, are you thinking of suicide? And they told you, and then they end up like this. So it's really important to be tolerant and mindful of, is this an emergency or is this not an emergency? And I don't mean to make that sound like that's a simple decision. There is nothing more humbling than this work. Even for someone who's trained to talk to people about suicide, every single case is hard. Every time I discharge somebody home, I leave the room and I'm like, oh, I hope that was the right decision. So I'm not saying it's easy, but we also can't put everybody in a paper gown, right? And so we do have pathways. And the clinical pathways, that triangle I showed you, we have plans for how to make this practical and patient-centered, how to make it patient-centered so you don't make the patient feel like they're sorry they ever told you and they're never gonna talk about this again. Okay, so there's 2 ways to screen positive on the ASK, like I told you. There's acute positive and non-acute. So the acute positive is the one that everyone has to be prepared for, but is the least, is the rarer event, right? So it's yes to 1 through 4, and then a yes to that 5th question. So this means this is an emergency. This patient might try to kill themselves, so you can't leave the patient alone. And then you follow whatever your procedure is for standard of care for patients that are at risk of killing themselves. And they usually need to be watched and an emergent psychiatric evaluation. For the non-acute positives, that's yes to 1 through 5 and a no to question 5. And this means that risk was detected, but it's not an emergency. You're glad you picked it up, right? Because it's good to know that, and I always tell people in a medical system, like, what if the patient gets bad news and they have a history of trying to kill themselves? That's important for the provider to know, right? But this patient, the non-acute, and I've had in-person conversations with the Joint Commission about this, and they want people to use tools in the evidence-based way that they were intended to be used. This patient can be left alone, and these are most of your positive screens. This patient, if they don't want to wait for the brief suicide safety assessment, is allowed to leave against medical advice, like they would for everything else, right? If someone has a skyrocketing blood pressure, and you say, you're in a hospital, and you're just like, I'm gonna get a cardiology consult, and they say, I don't wanna wait, no one tackles them in the hallway and puts a security guard on them, right? But suicide is treated different, suicide risk. And so the patient is told it's good care for you to stay for that next step. And if they don't want to, then you have to sign them out AMA. Okay. So again, this is, I don't expect you to read this. This is what a fleshed out clinical pathway looks like. So there's steps so that you know exactly what to follow. And every setting who's going to screen for suicide risk should have a fleshed out pathway. But it all comes down to these 3 steps. So however you decide to manage these 3 steps is how you flesh out your pathway. Okay, so many of you maybe are going to be doing that brief suicide safety assessment if someone screens positive. And so who can do a brief suicide safety assessment? Well, it should be a clinician. Ideally, it's a mental health clinician. It's a social worker or some other mental health clinician. But as we know, we don't all have sites with mental health clinicians. And so it could be the physician, it could be a nurse practitioner, it could be a physician's assistant, or someone else that is specifically trained up to do this brief suicide safety assessment. Because this person is the decision maker on what's next with the patient. So there's 2 tools that you can use to do a brief suicide safety assessment. There's a very commonly used tool called the Columbia Suicide Severity Rating Scale, and this helps with risk stratification. And the Columbia is a good tool to use on patients that screen positive because it's a suicide severity rating scale. We also created something called the ASK Brief Suicide Safety Assessment. And so I'm gonna, there's a lot of screening tools that are evidence-based. There's a lot of ways you can do this. I'm talking about the ASK because my research team created the ASK BSSA. So I just want to show you what a brief suicide safety assessment looks like. So first you praise the patient for talking about something that's really difficult to talk about, right? So they're telling you, thank you for telling me. I'm going to ask you a few more questions. And then then you go through frequency. And this BSSA is meant to remind you of the important things to ask. You ask about frequency of suicidal thoughts. You ask about suicide plan. You ask about past behavior. And then it has some prompts. You don't need to read this. It's on our website, but it has some prompts for the symptoms, how you ask about that. And then there's, the Joint Commission does say you need to use a tool with risk and protective factors. So we do talk about, people say, why do you want to die when someone tells you they're thinking of suicide? A lot of times people forget to ask, why do you want to live? What are your reasons for living? That's a really important question to ask somebody, because sometimes you get something that helps you decide that, oh, okay, someone will say, I would never leave my children. I would never leave my pets. And they say it in a way that's, helps you in your decision of what you're going to do with them. It's important to make a safety plan with the patient. I'm going to talk a little bit more about this. And then you come down to a determination. Now, when people say, I'm going to talk about this in a minute too, but when people see this BSSA, they say, I can't do that in 10 minutes or 15 minutes. Are you crazy? Well, this tool is meant to be a guide. You don't have to hit every single button on it. What you do is you use it to help you make your decision. Once you get to your decision, you stop. Because if I'm talking to a patient and they tell me they're thinking about suicide every single day, and I'm talking to a child and they say, I can't even do my math homework because I'm always thinking about suicide, and I have a plan, and I have the means, well, I don't have to keep going. This patient needs a full mental health evaluation, right? So I'm going to show you in a minute, but I also want to show you there's child versions of how to give this to kids, and we talk about how to bring the parent in. So this is really important. With respect to your talk, Dr. Sederi, there's on the life stressors, there is nothing more awful than losing a child, right? And then, so here's a parent being told that you have a child that might be thinking of taking their own life. So you're about to tell the parent who might not know. And, about 90% of parents don't know that their kids are thinking of suicide, right? And that's not because they're bad parents. And it's not because they're not paying attention. It's because kids keep this information to themselves most of the time. So if a parent comes in and you say, your child is thinking of suicide, did you know about this? Even if you say, did you know about this in a compassionate way, that's like, whoa. What are they going to say? No, I didn't know about this. They're going to feel bad. But if you say to them, is this something that your child shared with you, right? That's just one little shift that helps a parent say, no, I didn't even know about this, right? It takes them off the defensive. So we have ways to say that. And then it's important to ask if the parent is comfortable taking that child home now that they know they're at risk. Are they going to be able to keep them safe? And then, is there anything you would like to tell me in private? And right, because parents sometimes have things they don't want to say in front of their kids. Maybe there's a family history of suicide they want to tell you about. So it's important to get the parent alone too. So that brief suicide safety assessment, whatever tool you use, it all comes down to these 3 decisions you're going to make in that triangle, right? Did the tool say the patient was non-acute positive, but they're really acute positive? Sometimes that happens. Or the green, you know what? I went through the BSSA and this child needs something, but it's not urgent and they don't need it right now. Or the harder one is the yellow, right? Further evaluation's necessary. Like, it's not an emergency, but they do need a full mental health evaluation before I can let them go. So the BSSA comes in youth and adults and for all different venues, and that's available on the Ask Toolkit website. So I want to give you an example of how we turn research into practice. Just very quickly, we know from research that 1/3 to 1/2 of your positive screens are going to look like this. They're going to say no, right? That sole yes to the past behavior. So what's the bad news and the good news of this? The bad news is there's a lot of people out there that try to kill themselves. And so they're going to look like this. The good news is that it might not be what I'm going to call your business of the day. Maybe they came in for something else and you found this, but it happened, 20 years ago. Or it happened and now they're in mental health care and they have a safety plan and they're being treated. And so you don't need to do more. You screen them, it's good you know, right? But you move on. This patient's also gonna screen positive every time they come in to see you. So what we do is if we see this, and there's hospitals now doing this, then we add a sixth question. Say you were here in October, since October have you tried to kill yourself? They say no, everything else is no, your clinical judgment is okay, they move on, they don't need a BSSA. So for kids, there is this blueprint for youth suicide prevention that the AAP and the American Foundation for Suicide Prevention developed, and I got to be privileged as being a part of this. And this is, I encourage everyone who works with kids to go to aap.org/suicide prevention, and it's a really, really helpful website. Okay, so oftentimes people say to me, well, I can't screen because I have nothing to do with the patient that screens positive. I can't get them mental health access for 6 months or ever, so I don't want to screen. Well, the problem is that this person is thinking about suicide, whether you screen them or not, they're still thinking about it. So there are 3 interventions you all can do immediately, right? Safety planning, lethal means safety counseling, and you can provide the 988 number, which is the suicide lifeline, and the crisis text line, which is really good for kids. So very briefly, let's talk about a safety plan, because you could do a whole webinar on how to make a safety plan, right? So the first thing is you identify the patient's warning signs. So you say to the patient, what triggers your suicide thinking? And they say, well, every time my parents fight, I feel like killing myself. Or every time my ex-husband calls me, I feel like killing myself. So then you get the patient to write this down. And then what are your coping strategies? What are you gonna do if it's 2 o'clock in the morning and you're thinking of suicide, right? I'm gonna write in a journal. I'm gonna watch TV. I'm gonna listen to music. I'm gonna exercise. Whatever it is that gets them through, they write 3 of those things down. And then who are your social contacts that you could talk about this with? Who are your emergency contacts? And then reducing access to lethal means. So I'm gonna just touch briefly on something that also could be a whole day's seminar, but lethal means safety counseling, so important, right? Over half of our suicides in the US, and this is different from anywhere else in the world, are from firearms, right? And the problem with firearms is 97% of people who attempt suicide with a firearm die. There's no opportunity for rescue, right? So it's important, and you don't have to remove guns from the house, but they have to be safely stored. So we don't even ask people anymore, do you have a firearm in the house? We just assume they do, and we say, either you give them education, like I'm gonna give you some education of how to safely store your firearm. The bullets and the firearm have to be stored separately. They have to be locked up, especially when someone's at risk for suicide in the house. And then there's the medicine cabinet that parents especially don't think about. There's Tylenol, Advil, all kinds of over-the-counter stuff that kids get into, that kids' friends get into, that they can use to kill themselves, right? So you also have to put those away. And it's not on the forefront of a parent's mind. So you reminding them could save their life. Now, sometimes critics of that say, well, like the best example of this is when, so when someone is in a suicidal state, right? They're in a state of unbearable suffering. They just want the suffering to stop, and their brains are not working properly. So they're not using their good thinking, right? Because suicide attempt is not a normal reaction to stress. I rarely use that word normal, but I gotta tell you, like, that shouldn't be an option ever. And especially for young people, we shouldn't make it seem like that's an option. So they're not using their good thinking. So if you can distract someone away from their method, you could save their life, right? So I can't tell you like how many people I've interviewed where they said, I almost attempted suicide, and I'll say, well, what stopped you? Well, my cousin walked into the room, or my mother called me on the phone. Right? So you're trying to thwart someone's plan. So the best example for this is the nets under the bridges, right? So critics will say, if someone drives up to a bridge where there's a net under the bridge and they want to die, they're going to find another bridge. Well, research shows that's not true. If you can thwart someone's suicide attempt, you can save their life. So that's why you have to lock up pills and you have to safely secure firearms. You also can give patients these resources, and it's not only a suicide lifeline, it's not only 998, but there's the Trevor LGBTQ+ lifeline, there's the trans lifeline, there's all kinds of resources and local resources. So just to wrap this up a little bit, the ask was researched in these 3 states, is being used around the country. Here's some hospitals that are using it. I wanted to take a teeny break before we get to questions and just show you a very brief 3-minute video. It's geared towards kids. It's kids talking about suicide prevention. But I want you to, it's really for anybody. I show it to everybody. I show it to parents. So when you hear kids, you could just think people, because this goes for everybody. And I'm hoping it's going to work.
I have my ups and downs, just like anybody else.
Maybe more than anybody else.
I can be hard to figure out.
And I like my privacy. I don't want you looking over my shoulder all the time.
But you know your kid better than anybody else. And if you think he's acting different than usual,
Acting really down, crying all the time for no good reason.
or getting really mad, not able to sleep, or sleeping too much,
Shutting her friends out or giving her stuff away.
acting reckless, drinking, using drugs, staying out late,
Suddenly not doing stuff he used to love.
or doing stuff that's just not like him.
It might be nothing to worry about. It might just be high school.
Or it might be something more. He might be depressed, not just feeling down, really depressed.
It might be that your kid is thinking about killing himself. It happens. More than you think. More than it should.
And people say, I had no idea.
I thought it was just a phase he was going through.
I never thought she'd do it.
I wish he'd come to me.
I wish she'd said something.
I wish I'd said something.
When it's too late. So if you think your kid's acting different, if she seems like a different person, say something.
Say, what's wrong? How can I help?
And ask her straight out. Are you thinking about killing yourself? It doesn't hurt to ask. In fact, it helps.
When people are thinking about killing themselves, they want somebody to ask. They want somebody to care.
Maybe you're afraid you'll make it worse than you ask. Like, you'll put the idea in their head.
Believe me, it doesn't work that way.
It doesn't hurt to ask. In fact, the best way to keep a teenager from killing yourself is to ask. Are you thinking about killing yourself?
And what if they say yes?
Or maybe.
Or sometimes,
Well, here's what you don't say.
that's crazy.
Don't be such a drama
You're
queen.
making too much of this.
That boy's not worth killing yourself over. It's not going to solve anything.
You're just trying to get attention.
You're not going to kill yourself. What you do say is,
I'm sorry you're feeling so bad. How can I help? We'll get through this together.
Let's keep you safe.
a lot of people think about killing themselves, adults and kids. Most of them never try it, but some of them do. So if your kid says,
I'd be better off dead. Can't live with this.
I'm gonna kill myself, take her seriously. Find someone she can talk to about it. Someone who knows how to help.
Okay, very powerful video, right? I mean, I've seen this like 100 times, and every time I see it, it's compelling to me. I encourage you all to, I showed most of it. It keeps going, and if it's the Mayo Clinic, and if you just Google Mayo Clinic Youth Suicide PSA, it comes up, public service announcement. And I can also send you the link to pass around. Okay, so what does someone want from you when they tell you they're thinking of killing themselves? So the first thing is to stay calm, right? And so I'm gonna ask you all tonight when you're brushing your teeth to look in the mirror, and I want you to practice. Like, what are you gonna do when someone says, you're gonna say, are you thinking of killing yourself? And they say yes. Then what are you gonna do? So this is something that we don't all just naturally know how to do. It's awkward. It's really awkward. I'm about to show you a resource that says seize the awkward, that gives you some more clues. Nobody knows how to do this. It's awkward even for me. and I developed this tool, it's still awkward every time I ask somebody. It's hard to get those words out. So be present, listen, and be empathic, which I know you all know how to do because you're all interested in behavioral health, otherwise you wouldn't be here. So you can provide hope and strength, especially if you know the person, right? You can talk about their resilience, how much they've been through. And the language you use is important, right? We don't say commit suicide anymore or successful suicides. We say die by suicide because committing sounds like some kind of crime. It's important the language you use, right? So you be compassionate and you talk about it, and here's some things you can say. I notice you haven't been yourself lately. Is there something bothering you? Now, this is more something you can do in your personal life, right? Professionally, we have the screening tools. Parents say to me, should I use the screening tool on my kids? Or people say, should I use the screening tool on my husband? And I'll say, no. Don't use the screening tools on your friends and family. You don't need a screening tool because you have the luxury of this relationship with them, right? So you're trying to start a conversation. Just like, it's not easy to talk about hard things. So these are some things you can say. You haven't been yourself lately is a good one, right? I know you feel awful right now. I promise you it's not going to always feel this way. Let's talk about it. I'm sorry you're feeling so bad. How can I help? These are things that you can say. You can also foster resilience. Restart your computer to finish the installation of a safety patch. That's okay. Oh, that's a weird one. That is not something you should say, right? Okay. Don't say that. That will totally throw them off, right? Okay. Okay. Right. Okay. All right. Good. Okay. That was right. Okay. All right. So what is resilience, right? So it's the ability to bounce back and recover after something really bad happens, and we all have it in us. Everybody has the potential to be resilient. It needs to be fostered, though, and we are all a community, so we have to foster resilience. And resilience is messy. It doesn't mean that the person, like something bad happens and then you're immediately okay because you're resilient. No, you might cry, you might have horrible days, you might, feel like you're losing it. That doesn't mean you're not resilient. It means it's something to get through and to try to get to that other side. So with parents, when I work with parents, I talk about strengthening the connection with your child. Try to set that stage, that family dinner, no matter what it is, no matter who's at the table, like so important. Or the drive in the car when you're not looking at you, right? My daughter said to me, "Mom, why do you always bring up these subjects when we're in the car?" It's like, it's because I'm not staring right at you, it's not an accident. And be willing to hear, be willing to listen. Listen more than you talk. So important. Just listen, especially to kids, let them talk. You're not gonna agree with everything they say, but listen. And be curious. Instead of saying, "Why did you do that?" You can say, "I'm just curious why it's so hard to put your dishes in the dishwasher." You could be curious. Be consistent and persistent. So, "Oh, Mom, you're always asking me about this." Yeah, you're the one who can do it, right? And then guide by example, right? So if every day you come home from work and you're like, "Oh, that was a stressful day," and you take a bottle of wine and you pour yourself a glass and you sleep. Now, I'm not against wine and drinking wine, but they're watching you, especially the older kids. They're watching how they might look like they're not listening anymore, but they're watching you. How do you respond to stress, right? And then advocate for them when it's appropriate. So again, these are the screening questions. You're not going to give them the screening tool, your friends and your family, but you can ask these questions. in a different way. You could, but everybody here can say, I'm worried about you. Are you thinking of killing yourself? I want you to all tonight practice saying that line, because it's hard. It's hard to get out of your mouth. And you're embarrassed, and you don't want to make them mad, but you rather them be mad than dead. So it's really important to ask. And then the other questions you can ask when you're worried about someone is, do they have a plan to kill themselves? And how would they do it? And do they have the means? If they're saying they're going to kill themselves with a gun, do they have a gun? You know, do they have trusted people to talk to? Every child needs a trusted adult, but every adult needs a trusted person to talk to, right? And then are alcohol and drugs playing too big a role? And have they ever tried killing themselves in the past? Because that's the #1 predictor of future suicide. So again, things you can say when they're non-acute positives. You can say, even if you don't know, you can say, I'm not sure the best way to help you, but I want to get you help. I know you need help. You can couch everything in safety. You don't have to keep talking about suicide. You can say, I care about your safety. Your safety is my #1 priority. I want to keep you safe, right? It's hard to argue with that. So you ask them who to reach out for help. Okay. So these are, and I'll give these to, Kim, I'll give these to you so you could send these around, but these are websites that talk about starting these awkward conversations. And then something that's so important, maybe even the most important thing, is taking care of yourself. You guys are all caretakers of other people. So this is, you know, on an airplane, they tell you to put your oxygen mask on first. This is a field with big burnout. I'm hearing this more and more everywhere I go. It's like, you're hearing horrible things from people. You're sitting beside them and listening, and that's a gift. But you need to take care of yourselves too, because you need a gift of some peace as well. So in order to take care of other people, you have to take care of yourself, and that's so important. All right, so in summary, screening is such an important way to start that very difficult conversation, and it helps you identify people at risk, and it's important to ask directly. Remember that the 3-tiered pathway is how you can develop a clinical pathway. We're always here at the NIMH. My team is always available to help you figure out a pathway. Starts with a brief screen, followed by that brief suicide safety assessment that determines what happens next with the patient. And then the 3 interventions that can make a difference: the safety planning, the lethal means safety counseling, and 988. So everyone here can make a difference. I'm going to open it up to questions now. Oh, I'm going to end on my favorite quote, because this was something my grandmother said to me when I was little, and I was like, what? I have no idea what this means. Don't let perfect be the enemy of the good. What does that mean? Well, there's a vast, infinite difference between doing nothing and doing something, but a barely noticeable difference between doing something and doing something perfect, right? We can't get this perfect. Otherwise, as Dr. Sideri said, everybody would have a psychiatrist, and you'd be able to talk about this, right? So you do the best you can, because you could save somebody's life by just doing good enough. So I'm going to end it there on my thank you slide. There's a big team of people to thank, and thank you all for your attention. I appreciate it.
Got time for a few questions, if anybody has any questions. Say that again.
Yes, so the question was, have I seen this happen effectively in remote care settings? So it's a great question. Rural health is really now on the radar screen of a lot of government agencies on NIMH's. I have a research team that did a study in West Virginia, in a rural part of West Virginia, and saw this work effectively in primary care. I've seen it work effectively in places in Alaska where there's like 2 psychiatrists in the state. So it's harder in rural areas, but that's what we're trying to do, is trying to help rural areas be able to do this effectively. But it's a great question.
The 988 crisis line has gotten a lot of bad press about breaking down sometimes. How do you feel about giving these patients this as a resource and then maybe it doesn't always work?
I'm sorry, I didn't hear the very first part of what you said.
The 988 crisis line has gotten a lot of bad press that it doesn't always work properly.
Yeah, okay. The 988 was off to a little bit of a rough start. I will tell you, because there is a work group, I've just been invited to be on it actually, that is working on the 988 and trying to make it better. But one change that just happened is that it's now more geospatially related. So what was happening is the 988 is supposed to connect people with their local suicide hotlines and their crisis text lines, and it was missing people in certain areas, and so they're trying to align it better. So I would still give patients 988 because I think most of the time it works, and I think it's getting better and better, and there's definitely people from SAMHSA that are working really hard to make it more effective.
I just wanted to share, I have a son that is high functioning autistic, but he quite often say that he wants to kill himself. And we have been through counseling. In fact, he's in counseling now, and we go through that quite often. So is there anything that I can do or say to be able to help him through this? Because it's, I mean, when he gets frustrated, it comes up quite often.
Sure.
We wish he was dead.
Yeah, so that's hard, and people with autism, and we're learning this from our study, are at higher risk for suicide. So one of the things you can do with him, is he verbal? Yes. So I talked with a group about this yesterday. So there's a lot of people, and not just your son, but a lot of cases where people talk often about suicide. They have chronic suicidal thoughts. So it's important to ask them so that you engage them. And how will I know? Because I care so much about your safety, and you talk about wanting to die a lot, how will I know when it's an emergency? What should be my cues? Because my number one thought is to keep you safe. So let's have a plan of how I will know when this is you being frustrated and this is you feeling like you're going to do something to kill yourself. And so that's just one strategy. It's hard, but that's one strategy I can think of with anybody who is repeatedly talking about suicide.
My question.
Hello.
Think it's working now? Okay, yeah. So I work in rural healthcare, and I'm a LCSW. I commonly work with crisis screenings. It's a Is this, does this work? Okay. So one of the barriers that we often is that we have a patient who it's a dead zone. All right. Dead zone, I guess. Okay.
Check, check.
So a lot of the time, one of the barriers that we face is that we have adults, especially single mothers, who are really struggling with suicidal thoughts. They're overwhelmed. They have very little support systems in their area. And whether it's a single mother or it's an elderly individual who's caretaking for their mother or their father, is that they can't find services for their parents or the people that they're taking care of. My question is, what are some resources that we have access to help them keep their people safe while we find them care while they're getting the care that they need?
Okay, so what are the resources for that, for the patients that you're taking care of?
Yes, in the event that they would need something like childcare or they'd need respite care for their, do you know of any resources? Because that's a battle that we constantly struggle with.
That's a great question. So I don't know of those kinds of resources. And there's probably people in this room that know that better than me, especially for local resources. ABIN probably knows. But what you're talking about is really important because, so there's some suicide risk treatments that focus on what's called the drivers of suicide, right? So maybe these single mothers who are stressed and they can't find a job, or they can't take care of their families, or they're taking care of their own parents. This treatment, it's called CAM, C-A-M-S. It focuses on fixing those drivers because you're recognizing something that's important. Like sometimes if you could help someone with these really practical things, you might reduce their risk for suicide, right? I think that's what you're asking.
Absolutely.
Yeah, and that is so true. So it's not just, okay, we're gonna do cognitive behavior therapy with you, which is really good treatment for suicide risk, but you have to take care of the person's living in a life and they need help. And that's where these social determinants of suicide risk really come into play. And so that's a really important resource to have, is how do we get people help so that it reduces their risk factors, their stressors. So thank you for bringing that up. And can I count on you to get him resources for that? Okay, thank you. Somebody else had their hand. Oh, yes.
I was working as a nurse practitioner in a rural health clinic, and the patient came in, and her reason for coming to see me was because she was suicidal in the moment. Her plan was to get in her car and to drive it into a light pole. Well, obviously I couldn't really let her go. Called the ambulance, they took her to the ER. Well, by the time she got from me to the ER, she got scared, and she told the ER doctor she was not suicidal. She didn't know why I sent her over there. They went ahead and had her sign a contract. They let her go. She slit her wrist the next day. So what do you do when they lie?
Yeah, that's another great question. You bring up a few points in there that's important. One, we don't do safety contracts anymore. And when I was in training a long time ago, safety contract was the thing, right? Sign this piece of paper that says you're not gonna hurt yourself, and then I go home and I sleep better that night. Safety contracts don't work, as you can see. So instead of safety contracts, we do safety planning. We assume that this person is gonna have more suicidal thoughts and think about killing themselves again, and we make a plan for it. What happens when patients lie? Well, you know, that scenario you're giving me happens a lot because over time people start to either get scared or annoyed or frustrated, and then sometimes people learn what to say to get out of getting treatment. And that's hard, right? Because sometimes people are gonna lie. I think we still have to aim for those people that want help and wanna get help. With that person, they should have had a safety plan instead of a safety contract. But just like in medicine, like we don't make the diabetes treatment plan around people who aren't gonna take their insulin, right? We don't do that. We shoot to the people who are gonna do the treatment plans. And so that's one, you know, we still have to screen. There are gonna be people that slip through the cracks. And I think safety planning, lethal means safety counseling can help with that. But there are gonna be people that don't wanna talk about it. And there will be people that die. And I have to say that because in every field in medicine, like there's cancer patients, like 90% of childhood leukemia patients get cured, but there's still patients that die. And the same thing happens with suicide. People zero suicide's a great initiative, but it'll probably never be zero, right? And I'm saying that because over half of mental health people have lost a patient to suicide, because unfortunately some people are going to slip through the cracks. So we're trying to do, this is where I'm saying good enough has to be good enough. Like, we're trying to do the best we can. Safety plan, lethal means safety counseling, and 988. And, you know, that's the best that you can do. She did live. Okay. Oh, good. Good. Yeah. I mean, that's right. But we can also, and you know, it's so hard. Every single case is different. I can't give you a blanket answer for any one of these cases, right? Because every single one has a nuance that's different. But let's say that patient came in, and instead of sending her to the ER, right? Because that's what we do. We get worried and we send people to the ER. But let's say instead of that, let's say it was an integrated behavioral health care setting where somebody was working with her on the safety plan there, and she didn't have to go to the emergency room, right? Then maybe she wouldn't have gotten scared, and maybe she would have gotten different kind of help. So I think that's an important example to highlight why sometimes you can do some harm by overreacting to people.
We got time for one more question. We'll let Ms. Valerie.
Okay, yes, so for those patients that you offer for them to reach out to you, and if they don't, what is the follow-up, the suicidal plan? What's the average follow-up time when they're not reaching out to you, where you call them to check on them?
Yes, that's a great question too, because one thing that's very effective and simple is something called caring contacts, where patients, there was a study done a long time ago where just a phone call to a patient a few days later, or a postcard that went in the mail that said, "Hi, you were here for a visit, I'm thinking of you," it started to reduce suicide. Something as simple as that. So follow-up phone calls, that's another thing you can do in rural areas. Someone comes in and they don't have access to mental health care, you can have them come back to your office in a few days. You could have someone call them in a few days. So, you know, a few days, it's good to check up on. Next week, it's good to check up on them. I hope that answered your question.
I know we could keep going, and we will all still be around, and Dr. Horowitz will be around still. So it's time to go have your break, get your lunch, come back in here, be sitting at 12, because we will have a great panel to go.
Thank you.